Hello, everyone. This is Nayiri from Low Carb and Fasting. Well, today's episode is part of the series that covers metabolic health crisis or the status of metabolic health. It may not be in crisis in your country. So in today's episode, we're covering Mexico. In the previous episode, we covered India. So if you haven't seen that video, it will be on the channel. Check it out. So today I'm very excited to talk about metabolic health, the situation of metabolic health in Mexico, the challenges and possible solutions. Dr. Carlos Zumarraga, I hope I pronounced that correctly. Welcome to Low Carb and Fasting.
Thank you very much, Nayiri. It's a pleasure to be here.
Dr. Carlos, can I just call you Dr. Carlos?
Sure.
Yeah. So why don't you introduce yourself to our audience, your medical background, and how you got to discover the low carbohydrate way of living?
Yes. Sure. So I'm a physician here in Mexico, and I did a little bit of research in the US, in the University of Pittsburgh. So I'm an MD scholar, and I've been working with metabolic health since 2016 as an evolution of my practice. At the beginning, I was doing research in the cell communications and stem cells and cell regeneration. But I found that the nutrition is an excellent way to create the gene expression and to stimulate the healing in patients that have metabolic damage. So I started treating patients with diseases like fatty liver disease, with NASH, non-alcoholic steatohepatitis. And I was really measuring not only the laboratories of the patients in the liver enzymes that they get better, but also in the anatomical aspect of the organ. So I was also following with ultrasounds the liver, and I was watching the liver to get healthy with less fat and visceral fat and the liver fat. And also we follow a little bit the pancreas with the dual cycle of the pancreas liver in the diabetes. So it's using nutrition as a medical intervention to treat metabolic diseases, mainly based on insulin resistance. So I've been doing that in my clinic. My clinic is called the Clínica Keto, and is located in the south of Mexico, in Yucatan. And I treat all kinds of patients with obesity and diabetes and polycystic ovarian syndrome, liver problems, and others. Sometimes we change a little bit the nutrition to treat autoimmune diseases or to help with autoimmune diseases. Sometimes we modify the nutrition to help with oncology, with cancer. And sometimes we use nutrition just as helping the athletes to perform better and to adapt to a ketogenic way of eating and perform well in athletics. So that's what we do in the clinic here in Mexico.
Which part of Mexico are you located?
I'm in the south part, in the Yucatan Peninsula, it's called. And so we are in the south part, close to Florida and to Cuba. We call it the Yucatan Channel, and we are the city that is in the middle.
Dr. Carlos, would you say that there is a metabolic health crisis overall in Mexico? Of course, it may vary from one part to another, but overall, is there a crisis like there is a crisis in the United States, in most of Europe, in India, in the Middle East? Wherever we look, there is a metabolic health crisis. What's the situation like in Mexico?
Yes, definitely. Mexico is one of the most severely damaged countries in metabolic health. Maybe because we have a lot of influence from the number one country with problems with metabolic health, that is the US. So we are very close to the US, and we have a lot of things in common. And for example, the guidelines, the nutritional guidelines that we develop in Mexico, basically are based on the development in the US. So we have a lot of things in common, and some things are good, and some things like the nutrition is something that is causing problems in Mexico as well. And it's important also to talk about genetics, because genetics is a predisposing factor for developing metabolic disease. But it's very important to make a differentiation between genetics and epigenetics, because now in the media, maybe in the government also, in the high institutions, they are talking about obesity as a genetic disease, but in reality, it's just a multifactorial disease with a genetic predisposition to develop the disease. But you have to trigger the disease with the intolerance, with the problem that you have with the intolerance, and this is mainly carbohydrates. So in Mexico, we have a lot of genetic predisposition, and when we give to the population a diet that is very high in carbohydrates, and what we have is problems with all the insulin resistance and metabolic health. We are not protected from metabolic health, as some populations are better fit to tolerate carbohydrates, but in Mexico, the Latino community and Latin American community were very sensitive to the problem. So yeah, it's a huge problem in Mexico.
And this is only an observation, and I'm not a physician. I'm a researcher, nutrition researcher, and a coach, but I'm not a physician. However, I couldn't help but observe when I lived for 6 months in Mexico, all around me, I would say at least 70% of the people were overweight or obese to varying degrees. That's one observation I made, and I was actually surprised because on a coastal town in Mexico, you wouldn't necessarily expect, you'd expect more athletics or the builds. They weren't there. They were a minority. The second observation I made was almost everyone in the scorching heat, instead of having a bottle of water in their hands, they had soda, as the Americans would call it. They were drinking Coke, or but Coke was the biggest one. I think I could see Coca-Cola. So that's what they were drinking instead of water in the heat. That was another observation I made. And the third observation was at the restaurants, when I would just order the fajita without any bread, without any rice, without any beans, and that they would go like, "Are you sure you don't want the tortillas? You don't want the rice?" They're a big part of the diet, right? They're ingrained. It's the traditional diet, the beans, the rice, either corn flour bread or wheat flour. How do you solve these issues when they're so ingrained in people that they don't even realize that drinking water and drinking Coke are very different things? How do you solve the problem? How do you approach it?
Yes, definitely. The way that we are used to is we have a lot of influence from the the soft drinks industry, and there is not really education about that it's better to drink water. Water is what we should be drinking, and so everybody is reaching a soft drink. Some efforts have been done to to label the products in the content of calories. But the problem with this labeling is that even it's a good effort, it's not enough, because it's not based on the metabolic understanding of the problem. It's based on the caloric understanding of the problem. So that's not fixing the problem, but it's an effort that's good. It's good to do. And yeah, in Mexico, like in the US, we have, I think the adult population is like 80% or 87% is metabolically sick. And we see this in not only in the obesity epidemic that we have, but also in the, the laboratory and the metabolic syndrome diagnosis that we do. So it's also very good to make a differentiation between the obesity epidemic and the metabolic disease epidemic, because they are parallel diseases. They are closely linked together, but they are different in a way. So the problem is the fat that we accumulate in the viscera, and the visceral fat, and all the markers that we develop when we eat more carbohydrates than we tolerate. And this concept is called the personal carbohydrate threshold. So once you are above your carbohydrate threshold, then you start making all the physiological manipulations. Your body is going to try to keep homeostasis. So it will shift the carbohydrates to fat, to lipogenesis de novo. So the adiposity, it's caused by the carbohydrates. And then when we start developing adiposity from this intolerance and this saturation of carbohydrates, then we start developing inflammation and all the compensation that we see in the metabolic syndrome, with hyperinsulinemia as the main problem. So when we have hyperinsulinemia in the patients, we have the markers of metabolic disease that we see in the population, that is high triglycerides, low HDL, obesity, but more than obesity is waist circumference, high blood pressure, essential hypertension, and prediabetes or elevation of glucose. But all of this is caused by the hyperinsulinemic state that is caused by the high carbohydrate diet that we have. So yeah, it's a huge problem related to education and to know that some foods, even if they are natural or they are culturally good, they are in reality too much for the patient, like tortillas, like beans, like what else do we eat a lot here? Some fruits. We are a culture that we have a breakfast with fruit juice, and this is as bad as the Coke because of the fructose. So it's not only the products that we have problems with; it's also the natural foods that are unhealthy for the patient that is intolerant to carbohydrates. So a lot of education is needed to prevent and to correct the diseases, like I guess everywhere else in the world.
You mentioned education, and I think that's a great tool. We need to educate the public, and it's going to take more than one voice. It's going to take collectively all of our voices to educate. And your videos online on social media, and you're speaking in Spanish, so people can relate to it. So your efforts are really commendable. We need more voices in this community. So how much, going back to education, how much does the mass media in Mexico cover health and the low carbohydrate diet? Is there any talk about it, or is it like something like a fad diet? We don't talk about it. We just tell the public to watch their calories and do a bit more exercise.
Yes, there is not only no mention of the therapy for metabolic people, for metabolically sick people. There is also an effort to block the information. That is it's very bad for the people that is in need of improving and for health. Because I say this because in the general public there is information about the keto diet because it works. So the people try to do it as a fat diet. That's the first thing. And then you have the medical community that is also not very helpful in giving the information to the patients, because the argument is that the ketogenic diet cannot be done for 15 days and then when the patients do the diet for 15 days and it works, they say, okay, you cannot do it more than 3 months. And then when the patient goes 3 months, they say, okay, you cannot do it more than 6 months. And then the patient do it for 6 months. And this is a problem because the patients are getting better, are stopping using medications, stopping, the potential side effects of the medications. They are getting leaner. They are decreasing the visceral fat. All the markers are improving. And then because of the fear that there is something bad with the diet because my doctor told me that I cannot do it more than 6 months, then the patient goes away from the diet. So what happens is that the patient goes above the carbohydrate threshold and he starts getting sick again. And then the patient starts needing medications again. And then they say, you see, it doesn't work because you need medications. But the patient is only needing medications because the patient just eats what doesn't tolerate again. So that's a big problem. And the other problem is that the diet, the ketogenic diet in reality, should be seen as a lifestyle intervention. It should be done long term. If you need the carbohydrate restriction to be healthy, you have to be below your threshold to continue to be healthy. And with this, there is an aspect of the diet that has to be considered a lifestyle because you have to manage the remission of the addiction that many patients have. So we have to conceptualize the diet as a diet that will help you to continue with the diet and sustain the diet if you don't mess up with your brain, with your neurotransmitters in the brain, if you don't flood your brain again with dopamine and serotonin and norepinephrine, and the carbohydrates do this. So if you start eating trigger foods, the patients start having difficulty in sustaining the diet. And the trigger foods can be coming in the keto foods. So the keto products and the keto foods. So that's another problem that we have in the community, the patients, to be able to have a really strong and sustainable intervention that can heal the patient.
Yeah, one thing Mexico is known for is their sort of drug manufacturing industry. So you're not really importing stuff apart from, very specific medications, but the country manufactures, and a lot more cheaply than in the West, most of type 2 diabetic medications, blood pressure medications, etc. So would you say that because these drugs aren't necessarily hugely expensive, people have started seeing them as part of normal life? When one hits 40, you're almost expected to have, to be on 2 or 3 medications. And then by the time you're 60, well, you're old. And so, 8 medications, 1 for cholesterol, 1 for blood pressure, 1 for whatever. So would you say that mentality exists, that living on drugs from age, well, even 30 or 40 for the rest of your life is normal? Because that was the case in India in my last episode. People just normalize being ill and being on drugs. Is that the case in Mexico?
Yes, it's definitely the case. We have normalized sickness. And Dr. No says that human beings are not designed to be chronically ill. And I agree with that because, we don't have to be ill the last years of our life. We can be healthy even if we are older, if we have good nutrition and all the other aspects like exercise and, having good muscular mass, not having, treating sarcopenia or preventing sarcopenia. So all of this is important for having longevity and not developing lifetime diseases. And the majority of the diseases that we see in the elderly are lifetime diseases. What it means is that these diseases don't have to be present in the patient if you don't trigger the diseases. And the majority of those diseases are derived from insulin resistance.
Yes.
So that's what we treat with the ketogenic diet. We treat the insulin resistance and the chronic diseases that surface from this problem. So it's very normal for the patients here to have polypharmacy, to have 3 medications, 5 medications, 7 medications. And, and the other concept that is very bad for the patients is that once you have the medication, you will have the medication forever.
Yes.
So there is no hope for recovery now, for remission of the disease, because these medications in reality are not drug diseases. They are not druggable. This is from Dr. Lustig. He says that these diseases are not druggable. They are foodable. So if you treat the chronic diseases with drugs, you are not treating the disease. You are just treating the symptom of the disease. And this is a problem because you're condemned to have these medications forever. So everybody's taking medications. They have no concept of maybe to reduce or to eliminate the dose of the medication if you treat the underlying cause. And so it's always very difficult to educate the patient about, that it's possible to reduce the medication, and it's not something that we are doing because we want to do it. It's not because we want to do it. It's because the patient needs to be prescription because it's getting better. So we have to reduce insulins, we have to reduce blood pressure medications because the patient is getting better. But it's justified by the improvements in the laboratories, in the symptomatology of the patient, in the clinic of the patient, and the patient, when he or she starts the program, they immediately start to feel better. So they are never doubtful about removing the medication once they start doing the program. But as a concept, it's difficult to understand for somebody that is not getting better.
So let's talk about healthcare system. Each country has a completely different healthcare system. So are the treatment of chronic diseases like hypertension, type 2 diabetes, are these fully covered by the Mexican state? Or are people paying for these medications and doctor's visits and tests out of pocket?
We have the two systems. We have the private system and we have the public system. And the public system, it's complete in a way. I mean, you can go, you have your consultation, you can have follow-ups, you can have reference, to other doctors. You can have your medications. It's a right, I think, in Mexico to have healthcare. It's part of the constitution of Mexico. So the patients have coverage and they have medications. In the perfect system, they will have everything they need. But the system is not perfect. Many times you don't have a study, you don't have a machine to do a study, or you don't have the medication in the pharmacy of the institution, and then the patients have to buy the medication outside, or they have to do the study in a private clinic that have the machine or the equipment that is needed. So many times the patients have to buy the medications that they need for chronic disease, and many times they don't. So it depends of the institutions. We have basically 3 institutions here. We have the IMSS, Mexican Security Healthcare. We have the state-based system. Every state is responsible also for hospitals. And we have the federal system that is all the people, the employees of the federal government. They have the ISTE, it's called. That is it's a long name, but is the ISTE is the institution for the federal people, for referral personnel. So yeah, I mean, it's here in my clinic. My clinic is a private clinic. We have patients from the open society. Anybody can come here to the clinic. And sometimes I have patients that have the insurance, or they use the insurance from the Mexican government. Some people have private insurance, and so we treat everybody. And we, in reality, what we do is sometimes we add medications, but it's not common for me to do that. But in the majority of the cases, the patients that buy medications, they are happy to stop buying medications. For example, the fibrates that are used for high triglycerides in the metabolic syndrome are expensive here in Mexico. The cost is like 1,300 pesos a month. This is like $50 or $60. That it's a lot of money, I mean, to be paying for one medication every month. And this medication, we stop this medication immediately. We start the ketogenic diet. We give a little bit of omega-3 fatty acids, and then in 3 weeks, the patient is not having hypertriglyceridemia. It goes very, very low, the triglycerides, because we don't have the lipogenesis de novo. So even if we don't use the omega-3, we will have the improvement. The omega-3 is just protocol for the ketogenic diet that we use, but it's not something that we enforce to the patients to take. If they want to take it, they can take it. If they don't, it's not necessary.
What would you say to people? I'm sure you have those people in Mexico too, because they're everywhere, in every country, that would say, yeah, I would do the ketogenic diet, but it's kind of expensive, right? Because people think, that's what they say, it's expensive, because people, I think, partly think that they have to buy specific products, specific substitutes, or packaged, I don't know, protein bars, keto-approved bars. And of course, these will be expensive. I mean, of course, they are expensive, and they're not good for you. So, but if you keep it simple, it really isn't that expensive if you keep it simple. I remember the fresh fish, for example. That was just so, I mean, I couldn't believe how cheap compared to the United States, compared to the UK, compared to many places in the Middle East. I travel quite a lot, quite frequently, but fish was affordable. Meat wasn't too expensive either, but fish was so affordable. What kind of interventions do you use with your patients? And especially those that say, is this going to be a very expensive diet?
Yes. So the economics of the diet are very important. I learned the protocol, the diet with Dr. Eric Westman in the University of Duke. And he treats a population. I treat a population that is very similar to the population that they treat. And they use real food, and we use real food as well. So our clinic is based on the Duke program developed by Dr. Westman and Dr. Jansi. So what we have to do is we have to teach the patient how to eat from the food that they already eat. They have to know, they have to be educated about how to eliminate the carbohydrates from what they eat. For example, if they eat, for example, steak, or they eat pork. Pork here in Mexico is not that expensive. With a little bit of tomato and onions, and grilled onions, and a little bit of beans. We call that pokchuk, is the classical example that we give. We tell the patient, you have to stop. You are not going to eat the beans. You are not going to eat the tortillas. You're going to eat the meat with a little bit of onions, a little bit of tomato. But your principal or your main food will be the protein. If you don't get full, you order a little bit more of meat. Fish is also very cheap. We are in the coastline here in Mexico, and it's not expensive to go eat or to have fish and cook it at home is very cheap. If you go to a restaurant, as everything, it changes. But the product is very cheap. And the people can do the ketogenic diet with fish. They can do the ketogenic diet with eggs, with chicken. So it doesn't have to be, white, how they call it, the Japanese cut, the wagyu beef doesn't have to be that. It can be beef that is raised here in Yucatan. We have also some ranches here that provide food to the city, and it's not that expensive. And so the ketogenic diet, when it's about real food and we don't give supplements in excess, and we don't give protein powders, and we don't focus on the on the selling the product of the cookies that are keto cookies or the keto products. When we don't focus on that, we can do a very clean keto, even though this concept about cleanness in the ketogenic diet is referred to red meat versus white meat. But in reality, for us, we can, in research, it says that red meat is perfectly fine to do. It's not increased risk for anything if you do it in a ketogenic context. But we refer to clean food as food that is real food. So if we don't go to the commercial aspect of the ketogenic diet, then we have a perfect diet. And it's not only, a perfect therapeutic diet, evolutionarily correct diet. But the most important part of this is that when you do a ketogenic diet with products, you are not really sure that you are having the decrease in insulin and the decrease in glucose and decreasing ketones from your own system, because sometimes the products have MCT oil, and then you can create the ketones in the urine, but you are not really therapeutic. That's one aspect. The other aspect is that the keto products can be trigger foods. They can be addictive. So that's a problem for the patients that have addiction to food. And it's like 10% or 20% of the patients that come. Not everybody has addiction to food, but or to carbohydrates, but some patients need abstinence, and this keto products doesn't work. They have calories also. So the calories also, even our school is not based on calories, but calories are important. If you're in a ketogenic diet, but you're eating 5,000 calories, you are going to gain weight. It's not. You have a metabolic advantage with the ketogenic diet, but it's not like you are protected from thousands and thousands of calories. So doing a real food keto, it's important for economics, for doing the program right, for reaching therapeutic objectives, for avoiding addiction, and I think this is the best way to give a medical program in a clinic to a patient that really needs the program because the patient is sick. So I think it's the most ethical thing to do for the patients to do this in this way.
Mm-hmm. My next point is about the, I guess what makes the situation or the solution easier in Mexico compared to, say, India, is that meat is already pork, beef, or even chicken, right? It's already a massive part of the traditional diet. People are already eating meat. So whereas in India, for example, we're not only cutting down or eliminating the rice, now we have to introduce some form of protein in there. But people in Mexico, I noticed every single dish at a restaurant was meat-based. So if you're vegetarian, you're probably going to starve in Mexico. I'm sorry. I would have, because I was a vegetarian for 30 years. And then about 18 months ago, I started eating meat. But I had a great time. I had a blast in Mexico. I never felt deprived or of anything. Even the restaurant experience was wonderful because I could see the what was the name for it? The pork. I can't remember the pork meat just being cooked on that like skewer.
El pastor.
There we go. Yeah. That's the one. Yeah. And it was wonderful. And I would always check with them if the marinade, because sometimes they would marinate it with
Yes.
pineapple juice and everything. But
Yes, yes,
beef
exactly.
and all the fajitas, for example, they were great. The only vegetables they would put in it was onions, as you mentioned,
Yes,
maybe some tomatoes and green peppers. Green peppers were always there. And these are perfectly low carbohydrate foods.
yes.
And I would have a big dish of it without the rice and the beans. And that's so satiating. I just have one meal. That's it. You never think about food again for another 23 hours. So
Yes.
it is doable.
Yes,
Right?
yes, yes. Mexico is basically protein-based, animal-based.
Yeah.
The protein that we use is animal-based. So, for example, here in my state, we are very big in pork. Even my father had a farm, and we work in a farm, a pig farm, for 20 years, and it was great. I mean, I love the farm. We worked there for forever. My childhood was based on the farm, and I used to to deal with all the butchers from the small town that is close to the farm, that is not in the main city, and I knew everybody in the town. So it was great experience. It's the way I was raised with pork. So we have a huge company here in Mexico that deals, I mean, in Yucatan, that commercializes pork. And the main dish here in Yucatan is this pork cut, that is the upper part of the neck of the pork, and is what we eat like traditionally. The problem, as you said, is the complements. The tortillas and the beans. Mostly the tortillas and the beans. Like I think South Africa has also a big problem with the tortillas and the maize and corn, and it was exported from Latin America. So they developed also the epidemic of metabolic disease because of the trading in long time ago with these new foods coming into the country. And so we have a lot of this maize, we have the rice, we have the beans, and this is something that you can have a patient eating the protein, but if the patient is eating the protein with the carbohydrates, then that's not good, because you have the insulin peak, and then you have the fat from the meat, and then you create fat from the carbohydrates, and you store the fat from the pork, and then you have it's worse. In a way, it's worse to have carbohydrates and fat together. So in Monterrey, for example, it's very important. The industry is very important for beef. Monterrey is the capital here in Mexico about the asado, that they call it, and the nutrition is based on beef. So yeah, we don't have too much problem about changing the protein in the patients here in Mexico. The problem is reducing the carbohydrates and the traditional foods.
So do you notice that when patients come to you and they start getting better, they tell you, Dr. Carlos, now my wife is, or my husband is doing this too, or, oh, now, my sister noticed how well I'm feeling, so now she's doing it too. Do you notice that? Or do you notice that people just tell your patients, oh no, this is dangerous, don't do this? What do you notice? Or a bit of both, maybe?
Yes. That's really, this is what happens. What you say is really what my experience is also. The patients take the information, and they start the diet for the whole family. And the only thing that I say, because sometimes they ask me because they don't feel, sure about what they are going to do with the family, and they ask me if they can use the diet for other members of the family, like kids, and I say it's okay if they are not taking medications. If they are taking medications, then you have to, do a clinical examination, clinical assessment to see what medications are you taking, etc. But in general, the diseases that are problematic with the ketogenic diet are diseases of genetics, of metabolism of fat. These diseases are really very serious diseases, and the patients usually don't grow to become adults. So if the families, they have kids 10 years, 12 years, 14 years, or it's no problem. If they have any question, they can call me. But the limiting factor is the medications, and the other families start doing the extended families start seeing the results, and sometimes they start doing the diet by their own, and sometimes they call me. So I think the organic growth of the ketogenic intervention is massive. I mean, we see only the patients that are really, they do the diet and doesn't work, or they do the diet and they develop hypoglycemia, and they don't feel, they feel bad, and they start looking for advice. One thing that happens very often in the patients is that they start doing the ketogenic diet for diabetes with no supervision. They are injecting, for example, insulin, and they start developing hypoglycemia. It's a dangerous situation. It shouldn't happen in this way. And so they eat carbohydrates, and they try to continue to ketogenic diet with the insulin. They get hypoglycemic again. They eat carbohydrates, and they never pass the next level of therapeutics, and they think the diet is bad. But what is happening is that they don't have the prescription of insulin that is necessary from day one of the intervention. You cannot wait. This is another aspect that the medical community doesn't understand. The traditional physicians don't understand that is. They tell the patient, okay, do the diet, and then when you lose like 10 kilos, you call me. In 6 months, I see you, and then I remove the medications. You cannot do that. You have to do it in the same day that you start the intervention. And also, another problem with understanding is that the physicians think that the diabetes and the obesity are related like mathematical model. And it doesn't work like that, because it's a biological, it's a carbohydrate intolerance. So they think that this, like a mathematical decrease in weight, will have a mathematical decrease in insulin. And this is a huge mistake that I see. And, the patients go, they try to do the low carb or ketogenic diet, just like that. And then the patients are having problems, and they call me. So that's kind of what happens in the clinic all the time. That's one of the reasons they call me.
That was so scary there. As a type 1 diabetic who does fasting, I actually do extended fasting as well, just to show the world that it can be done safely. As long as you know what you're doing, you can do it. No one should tell you, no, you shouldn't fast because you have type 1. No, you can do it safely. And that's the reason I do it. But also to regain insulin sensitivity when things are a bit out of whack. I just do a multi-day fast, and that's it. I'm back to normal again. But that's another topic. However, it was just such a scary sort of description there, taking the same large dose of insulin while on the keto diet. And that can be fatal. Hypoglycemia is not fun. It's not fun. It can be fatal. So you shouldn't do it without the support of your physician, unless you're confident and you know exactly how insulin works. You have all the knowledge in the world, and you know what you're doing, which most people don't. Most people need the support, right?
Definitely. I mean, if you have any disease, or you are taking medications, any kind of medication, you need to have a clinical assessment with somebody that understands the ketogenic diet to do it safely. The diet is not dangerous, but the context that you may have from your diseases and your chronic diseases and your medications is what is. It has to have to be taken, seriously, like you said. It's very important for the patients to understand that.
Dr. Carlos, we're going to wrap this up, but very quickly, what are some of the tests you run, like lab tests on your patients? And do you check their insulin? Because I know it's very, very uncommon to check insulin levels. So do you check for the insulin levels?
Yes, here in Mexico we are blessed in a way because I think I talked with the group in England with Dr. Unwin, David Unwin group. We were talking about the essay to do the insulin test, and sometimes they have problems ordering the test. Yeah. And we do it all the time here in the clinic. We order the insulin levels, but more importantly, we order the C-peptide. So the C-peptide are even more important than the insulin to make sure that you're not having a LADA patient and you're not facing a pancreatic failure in a patient that is going to go to a ketogenic diet and is injecting insulin, because you cannot stop the insulin in this patient. You can decrease a little bit the dose based on results, but you cannot stop the medication by any means. And the C-peptide is the good test that we measure. We also measure the antibodies against the beta cells of the pancreas to see, the autoimmunity there. And then, based on experience, we know if the patient is tolerant to the ketogenic diet and if the medication can be removed or not, based on the C-peptide. But we are very careful in this aspect. So these are two very, very important tests. We do, the blood cell count. We check the hemoglobin, we check the platelets, we check the hematocrit, leukocytes, all related to the cell counts, the bone marrow, and all of this. We check the blood chemistries, we check the glucose, kidney function test, creatinine. A big thing is that the number one cause of the renal failure is diabetes. And so when we give the ketogenic diet to patients with kidney problems, but they are not on dialysis, we can see an improvement in the clinical aspect and the laboratory aspect of the patients. Sometimes we see decrease in creatinine. So we improve the disease because of the glucose management that we do. And we check lipids, we check all the lipids, the lipid panel. We focus on the triglycerides HDL ratio. My final work with certification with Professor Notes was with triglyceride HDL ratio in my patients, in my population. We review some of the cases that we see an improvement in this ratio here in the clinic in Mexico. And it's impressive the way that we sometimes make an inversion with HDL triglycerides. So the triglycerides are 70 and the HDL is 73, for example. So it's less than 1. So this is very good. And we check that. We check the VLDL, that is very important. I think maybe is the most important lipid that we don't focus on too much, because the VLDL is what reflects the lipogenesis. So we check this production from the liver of this lipoprotein, and we check liver enzymes, ALT, AST, GGT. We check in the context of fatty liver disease if the patient is developing NASH. And so we follow these enzymes to document the remission of NASH in the patients. And it's also a very good marker. We check vitamin D. It's the only vitamin we check. We check free testosterone in females that have problems. They have clinical polycystic ovarian syndrome. We check TSH for hypothyroidism. For example, patients with lipedema, they develop, many times they have hypothyroidism. So, and they are not diagnosed. So many, we diagnose this often. And in the imaging, we check ultrasound, liver ultrasound, pancreas. We check pancreas, fatty pancreas. That is very important. It's something that is kind of new, but it's important for us. We do it since many years ago. And we check ovaries in polycystic ovarian syndrome. And then sometimes we do the CIC score, the coronary artery calcium score, to stratify risk for cardiovascular disease in patients that increase cholesterol. We have to know if the patient is at risk, future risk of cardiovascular disease. But this, in reality, we do it because the school is the way they say that we should do it. But in reality, we focus to cardiovascular atherosclerosis prevention, with decreasing the metabolic syndrome and the diabetes, and decreasing inflammation and vascular inflammation and hypercoagulability that maybe is more important. For example, in the people that have familiar hypercholesterolemia, they inherit a gene for coagulation. And maybe this gene is what is causing the atherosclerosis and early death in this patient, and not the cholesterol. Also, many of the patients with hypercholesterolemia that die at the early age, they have metabolic syndrome. And then in longevity, we see the cholesterol can prevent many diseases like neurodegeneration and cancer. And so having a good cholesterol, total cholesterol increase and even LDL can be protective in the elderly. So yeah, we do all of this, and we review the case of the patient, and then we start the intervention. We manage the medication. So that's the way we do it here in the clinic.
That's quite an extensive checkup. I think, any patient who lives in the West would be lucky to come to your clinic and have all of these tested, because you quite often, like, I can speak of the UK. This is where I receive most of my medical care. These things aren't offered. I've been type 1 diabetic, for example, for 45 years now. So just for prevention, my doctor said, I'm going to start prescribing you statins now. I said, why? On what basis? We said, well, diabetics have a higher risk of heart attack, which is correct. But my blood sugars are my HbA1c is in non-diabetic range. He said, no, but you've been diabetic for 45 years. I said, doctor, I'll take the statin, but can we do a CAC score test? So at least let's get an idea and see if it might benefit me. And of course, that wasn't covered. They couldn't do it. He just wanted to do the prescription. So next time I'm in Mexico, I'm going to look out for you. Dr. Carlos.
Okay.
I will put all your details below, and I encourage my audience to follow you, especially on Instagram. You're active on Instagram, and if you are a Spanish speaker, you will love Dr. Carlos's Instagram, well, reels, I think that's what they are. So thank you very much for your time today. Have a wonderful day in beautiful Mexico.
Nayiri, it's my pleasure, and I thank you very much for this opportunity.